Great. Good evening, everybody. Welcome to another edition of the DY Patil Postgraduate Lecture Series. We are very happy to have with us Dr. Shobit Garg and Dr. Shobha Nair. I've known Shobha for many, many years, ever since my PG days. So we go back a long way. We used to spar a lot in the wards, and now we do so on these kind of academic forums. She is a very dear friend, but also a very astute clinician. So is Dr. Shobit. He is not uh, where he is for no reason. He is a head of department at SGRRU Dehradun. But I will ask Dr. Shobha to introduce him. But we welcome you all, and we are happy for having both these illustrious psychiatrists with us. It gives me pleasure to introduce Dr. Shobha Nair to you. She is an alumni of the Department of Psychiatry at Nair Hospital. Like I mentioned to you earlier, presently she is the head of Department of Psychiatry at the BARC Hospital at Mumbai. That's the Baba Atomic Research Center Hospital. She has 28 years of clinical experience. She is a postgraduate teacher and guide for DNB Psychiatry. She is the president of Bombay Psychiatric Society presently. So that's a busy and a prestigious post that she is endowed with right now. She has been a lecturer at Nair Hospital in the past, and like I mentioned to you, she has been a postgraduate student of Nair, and she's done her UG from KM Hospital, Mumbai. So welcome, Dr. Shobha Nair, and I now invite you to introduce our speaker for the day and take over the proceedings. I'll be back at the end of the session to wind up and give my vote of thanks. Over to you, Dr. Shobha.
Thank you so much, Dr. Rashman. At the outset, let me thank you for inviting me to chair this very important session and also a topic which is of great interest to me. I mean, when we were doing PG in our late 80s, when we recognized patients because of their tardive dyskinesias. And I felt that since that time we had only the first generation antipsychotics. And so a lot of our patients, in addition to the stigma of having mental illness, the stigma was compounded by what one could see their odd abnormal movements, which occurred sometimes as part of their untreated disease, and sometimes, and many a times, because of our medications. And all our endeavor at Nair Hospital from then on was how to reduce and how to prevent and how to manage tardive dyskinesias, which though the patients themselves may not be that bothered when it is mild, however, it causes a lot of social embarrassment, and sometimes it progresses to real difficulties in eating and speaking and including even mobility. So to talk on this very important topic of mastering tardive dyskinesia from prevention to treatment for the postgraduates of psychiatry at the DY Patil lecture series, we have none other than Dr. Shobit Garg. It's a pleasure to introduce today's speaker to all the audience. He's a professor of psychiatry. Let me just share the screen so that you all can see his CV. Professor of Psychiatry at the Sri Guru Ram Rai Institute of Medical and Health Sciences, Dehradun. He is an academician with almost 20 book chapters, an avid researcher with 80 publications, associate editor of Archives of Biological Psychiatry, a reviewer in various journals, with a special interest and expertise in neuromodulation and bipolar affective disorders, and has held different offices in IPS as well as IAPP. A warm welcome to you, Dr. Shobit, and we are eager to learn from your talk. Thank you.
Thank you, ma'am. Thank you for the wonderful introduction. So can I share my screen, ma'am? Yeah. So first of all, I would like to extend my regards to Dr. Ashman sir, that he has given me this opportunity to deliberate in front of the future of the psychiatry our postgraduate students. And then I think our discussion we came down boiled we, our discussion boiled down to this topic, which is very, very interesting. It emanates from my postgraduate time in CIP, where uh, yes. So I think my slides are visible, and am I audible?
Yes.
Yeah. So I was deeply interested in tardive dyskinesia or movement disorders per se from my postings in chronic wards there. So their patients were there who were living in the wards since 1950s, or maybe some patients were from 1940s, and they had the exposure to the medications which were initially launched. So they were having these uh, very abnormal movement. So then it actually emanated my interest, and this was one topic which uh, I'm actually trying to come up with this in few forms, that I'll try to first explain the basic, that what is tardive dyskinesia. I'll try to differentiate in this topic whether how to differentiate a particular movement with another movement disorder, and I have actually put some videos with regards to that. And my disclosure is in similar regards. And most of the videos from patients we have taken with consent for educational purpose. Few videos I've taken from CNS Spectrum journal, where they have actually they have published an article and video-based study on TD. So few videos I've taken from there, and few from our outpatient department from in our medical college. So why we are talking, why we are speaking about this, addressing this very, very pertinent topic? First of all, because these are one of the few movement disorders which are the prevalence is high because they persist. So in acute exposure to the medications, so acute movement disorders, they'll actually remit or they will disappear, but these persist with time. They're pretty debilitating. They impact quality of life in severe sense, and god forbid if it seeds in an early age. So the in youngsters, so all of you must have known that the age of onset of schizophrenia as per CTP is 22.8 years. So if the patient, if such a young person gets exposed to antipsychotics, develop these disorders, so it can be catastrophic and highly debilitating. So with these background, I would like to go to the topic per se, where I'll be touching on some basics. I'll be touching on some historical background. I'll be detailing on some conceptual evolutions, risk factors, so that all you can pick up these risk factors early in your patients and anticipate these side effects. Because once you enter into the window, so probably it might get too late. We'll discuss this. So early detection. So the whole idea of the psychiatry or any medical field is early intervention, early detection. Something about epidemiology, not much. Clinical features we will detail with by the help of some videos. Ethiopathogenesis, I'll go into details, and management, because very, very important. Coming to basics, so supposedly this is a timeline, and I would like to have this as an interactive session. So any issues, please you can interrupt me, and any if I'm going fast, interrupt me, or if you're missing on to something, please interrupt me, because two slides of conceptual slides are very important to understand the whole concept of tardive dyskinesia. So if someone is on treatment and someone develops this graph is a movement disorder very, very early in the treatment. So we say that dystonias, acute dystonias, which generally happen early morning. You give a night dose of injection haloperidol, early morning patient would develop acute dystonias. And when we say that, okay, they happen after few days or few weeks of the treatment, but they are pretty reversible, we call it drug-induced Parkinson's or pseudo-Parkinson's. Okay. But once if we see that the patient is on longitudinal treatment and starts to develop a set of symptoms or set of problems due to the drugs, and it persists even after the treatment is discontinued. So there the concept of tardive syndromes pitch in. So I think Dr. Shobha Madam, Dr. Rashmi sir, we all know this, but this is the starting point. Very, very important. So basics are very, very important for postgraduate students because the foundation needs to be pretty comprehensively laid down. So how did this come up? So who was the first person who brought this into the picture, brought this phenomena? First of all, I'll come to the terminology. It's a rare union of two different dictionaries, tardive dyskinesia. It came with from French tardive and Greek kinin. So again, and it is also known as tardive stereotypies and rhythmical chorea by many of the authors. So we all know this picture. Who is the gentleman? Can I would like everyone to post your answer in the chat box. So who is the gentleman? Kindly post your answer in the chat box. And I've written, oh, he has given this. Yes, Emil Kriplin. Yes. So one of you answered. Sanjay has answered this. So treatment, even Emil Keprin in his patients, he was an astute observer. He had very good observation skills. So he saw that in his patients with psychosis, they had peculiar sprawling, irregular coriform outward movements known as parakinetic catatonia. It was translated in language. He called this parakinetic catatonia, which actually subsequently turned out to be tardive dyskinesia. And these two individuals, they did something which was remarkable. What did they do, Delay and Deniker? I would like the audience or delegates to post their answers. So I'm trying this webinar web mode to be little interactive, though difficult. So what did Delay Deniker did in 1952? Okay, so as rightly answered by one of the from the audience, the chat box is chlorpromazine was discovered. So I would like to have everyone's attention to this. Chlorpromazine was discovered by this surgeon who actually, because of his interest in surgery, he actually started discovering anesthetic agents. And actually, he discovered the effects of chlorpromazine. He encouraged three fellow psychiatrists that because chlorpromazine would calm down patients, so he actually told them to why not they can utilize this molecule in psychiatry. Subsequently, the observations were first brought into the scientific foray by Dilly and Deniker. So actually, he was someone who deserves the credit for the same. Subsequently, what happened then? Then there was series of so there was a concept which I think we all know that side effect will not come unless side effect will come. So that was an understanding amongst the psychopharmacologists. So they'll keep on increasing the dose of antipsychotics till a side effect will come, and this was the whole concept of neuroleptization. So, but then they found that, and once drug is off, the side effects would go off. But then there was a series of case reports which came that after chlorpromazine was withdrawn, so the side effects, specifically the movement disorders, they actually started to persist. And it was brought out, but this was in British Journal of Psychiatry. And these two gentlemen, Schonecker and Sigwald, one is from France, one is from Germany. They observed that these movements were persisted till 3 months and 27 months of withdrawal of chlorpromazine. So there people got interested, okay, something else. So there was a tug of war. So people who didn't want this phenomena to come up to discourage psychopharmacology, they resisted the efforts. Others who actually promoted this theory at this point of time. Subsequently, in this ACTA, Forbey actually published his findings till date, and he did, and he first coined the term tardive dyskinesia. So this is the paper which I could come across. So it's an MCQ also, and it's a very famous, the frequently asked question: who gave the concept of tardive dyskinesia? So Forbey et al. Coming to a brief snippet into the scientific or conceptual evolution. So when we talk about tardive syndromes, so there are various kinds of tardive syndromes. It's a famous postgraduate round question. So we call it tardive dyskinesias, dystonias, akathisias, tics, tremors and Tourette, myoclonus, chorea, tardive Parkinson's, withdrawal emergent syndrome, and also this a rare entity known as tardive pain, where it will actually the patient will continuously report pain subsequently after exposure to antipsychotic, even if the antipsychotic is withdrawn. So many people, they still argue that we have to compile these syndromes into one cluster, or we deal with this differently. So this argument will go on and on. For all practical purposes in this presentation, I would like that we will be specifically dealing with TD, tardive dyskinesia. In some sections, I'll be, if need be, I will be clearly telling you that if some other syndromes, tardive syndromes are being mentioned. So what, for this presentation, tardive dyskinesia will be dealt as a separate entity. So what is tardive dyskinesia? So audience, what is tardive dyskinesia? Okay, I'll make things easy. So it is a coriform movement. A coriform movement where you will have semi-purposeful or quasi-purposeful movements. What is quasi-purposive? Where the patient actually will try to show that the XYZ movement is serving some purpose. It will be available to the audience that he is doing serving some purpose. We will explain it with the help of some videos, but it is not serving any purpose. So this is quasi-purposive or semi-purposive, dancing, fluid, random movements, and involving different body parts and not in any rhythm. So these are non-rhythmic. Ethetoid movement, if you can look at this video. So I'm saying, see the tone will flow from one group of muscles to another group of muscles sequentially. So then this is ethetoid movement. So ethetoid movement, or it can be in stereotypic movement, which are uh, senseless and which doesn't serve any purpose, and these are spontaneous. So this is a definition of stereotypy. So tardive dyskinesia can be either of the three. Coming to conceptual evolution, as I said that previous slide when we talked about acute, in the middle of the treatment, and the tardive syndromes. So coming to tardive syndrome concept, uh, specifically, this slide becomes very, very important. So this is the illness. This is the baseline. Okay, supposedly the patient has received treatment, which comes to a point of discontinuation, but treatment is more than 3 months. So, but this red graph is a movement which is resembling dyskinesias, but it is happening before the treatment starts, even before the illness starts. So pre-morbidly, patient is carrying these movements. So these are known as spontaneous dyskinesias with a point prevalence of PP is point prevalence of 5%. Many people who are interested in this avid group in research, you can take this up because the prevalence range is very high. The range is very heterogeneous and high. The confidence interval is high. But they say that is why they are calling schizophrenia as subcortical psychosis, and they say that it is a matter of research. So we'll not go into the detail of this. So something which is coming before the illness onset is spontaneous dyskinesia. Something which is coming before 3 months of treatment intake, it is acute dyskinesias like oral rapid syndrome. So this is happening maybe immediately or maybe a few days or few weeks of starting of antipsychotics. So acute dyskinesias, example is rapid syndrome, where will be movement of the perioral musculature in the form of a rabbit. Supposedly, the treatment is discontinued and subsequently there is a movement coming up. So it was not present in this phase and the drug is withdrawn and this movement comes and it goes. So this is known as withdrawal emergent dyskinesias. Withdrawal emergent dyskinesias. So they will disappear within 4 to 8 weeks of discontinuation of the antipsychotic. So within 4 to 8 weeks, it should disappear. Now, when we talk about the the whole spectrum of tardive dyskinesia. So we say that something which is developing after 3 months of exposure to antipsychotics, which is persisting after the withdrawal of antipsychotics and beyond 1 month of oral intake of antipsychotics and 2 months of depot antipsychotics. So this whole spectrum is known as tardive dyskinesia. When we talk about as I shared, like the duration of exposure. Initially, it was 6 months. Subsequently, they said that it was 3 months duration of exposure of antipsychotics, and 1 month in elderly, as per DSM-4. But it should be present for at least a month with persistence of movements post 4 to 8 weeks. This is if it is disappearing within 4 to 8 weeks, it is withdrawal emergent. But if it is persisting more than 4 to 8 weeks, it is tardive. So as simple as that. But it should persist in itself. It should not be 7 days, 15 days, 21 days. It is there. It should be present for at least a month. And after an exposure of antipsychotics for at least 3 months. But in elderly, they have given a broader window where it is 1 month. So coming to DSM-5, DSM-5 has followed the similar path. Only difference is that they have removed this at least 4 weeks criteria. So probably the DSM-4 criteria is more broader than its previous counterparts. Now, when we talk about research, if anyone wants to do a research, so you will have to operationalize this phenomena of TD. So I hope everyone is with me that what is TD? Tardive dyskinesia is when there is more than 3 months of cumulative exposure of antipsychotics. Moments persist for at least 4 weeks, and they persist even after the discontinuation of antipsychotic after 4 weeks, or depot antipsychotics after 8 weeks. So we call it mnemonic of 3-1-1-2. 3 months, 1 month of movements, 1 month of discontinuation of oral antipsychotic, and 2 months of discontinuation of depot antipsychotic. That is how we actually ask our residents to remember this. So operationalizing means school learning gain criteria. So 3 months cumulative exposure, it is with us. It is saying use aims, we'll come to this later. And it has to be at least one area should be have of moderate severity, or two areas should be of mild severity. Now this is important. I want everyone's attention to this. They have categorically said that if we want to call it persistent TD, the movement should persist for more than 3 months, not 1 month criteria of DSM-4 TR. Probably DSM-5 took that away because of this confusion. But the reason behind Schooler and Kane gives is something like which falls into the criteria of persistent TD, that movements are persistent for more than 3 months, then actually the TD course becomes irreversible. We will discuss this in course in subsequent section. So this is a Glaser-Modgerson criteria, where it is another criteria which is also now pretty famous. I am not going to the detail of it. You all can go and read this. Coming to risk factors, very, very important. Can anyone elaborate some of the risk factors in the chat box? Maybe a couple of them. So I'm waiting. There are around 46 participants. Female, young age, old age. So age, fatty, okay. So maybe you're saying that some kind of a metabolic syndrome. Yes. Any other risk factor? Diabetic, okay. Yes. We'll discuss this. First generation antipsychotics, yes. Dodanil has answered this. Okay, so we move to so increase age. So age is the most important predictor of TD. So this is important. So postmenopausal women, maybe because of all the good effects of estrogen they would wear off, apart from cardioprotective effects. Then ethnicity is also one of the risk factors that has come up. Mood disorders. So this is important. So someone having a mood disorder like in bipolar disorders or unipolar depression, on antipsychotics is more vulnerable. For TD, what I do, tardive dyskinesia, diabetes, one of the answers also is polypharmacy and cerebral atrophy. Okay, and Saket has given a vivid description of concurrent use of anticholinergics. I think very good. Alcohol intake or substance use, brain reserve. So anyone having an cortical atrophy or going into decline or mild cognitive impairment, or we call, many times we say that bipolar dementia spectrums. So those patients are in pretty high risk of or past history of traumatic brain injury. So a very conservative brain reserve is there. So then dopamine receptor blocking agents will come to these, but first generation are more notorious than second generation. If you know that there is not a huge gap between the two, second generation risk is only one third lesser than first generation. Maybe reason being many of the category, the whole categorization of first generation, second generation is I suppose pretty faulty because risperidone is a fancy first generation antipsychotic, I would say. So movement disorders, other movement disorders, definitely like history of any drug-induced Parkinson's or any dystonias in young male. So these would make probably the brain more vulnerable for TDs. Now this is important that if someone is on depot antipsychotics, so our hunch will be depot means more movement disorders. So depot antipsychotics versus to oral antipsychotics, the prevalence is not different. It is same, almost same. But someone who takes drug holidays, so who would have a seasonal worsening of symptoms, would skip medications, and then repeatedly take medications, so the prevalence of TDs becomes high. So it is also one of the a weak risk factor, I would say. So coming to huge list of drugs, we all know that antipsychotics can cause TDs, first generation, second generation, then typical, atypical antipsychotics, antidepressants like specifically amoxicillin because of inherent D2 blocking property, and then SSRIs, SNRIs, SARIs, all these can cause, but let me tell you, these are in the form of case reports. So, but to create TD, a drug without having any dopamine modulating property can be difficult to imagine. In mood stabilizer, lithium, antiepileptic drugs, carbamazepine, many literature you'll see carbamazepine is also given to suppress TD. Then I would say that anti-Parkinson's drugs, so they themselves can cause a different spectrum altogether, going to TDs. But oral contraceptives like estrogens, we need to be, and stimulants, we need to be more careful in prescribing these. Coming to epidemiology, so when we talk about epidemiology, prevalence, so for postgraduate students, let us keep this very simple. TD prevalence is 20%, simple. But when we talk about Asia, 5%, in India it is 2.2%, which is probably underreported data. It's a biased data. And when we talk about incidence, so it is 5% per year. So if you want to remember very, very crisply, so TD prevalence is 20% worldwide and incidence is 5% per year. So when you see that every year the incidence would increase. So we calculate this and then again put it up. When we talk about younger population, as we said, old age is a risk factor, 5% in young age, 12% in old age. But for all practical purposes, two data you need to remember, 20% in worldwide prevalence and 5% per year is incidence rates. But when we talk about polypharmacy, because one of the answers in chat box is also polypharmacy by Dr. Tony Thomas, he is correct that if we combine FG and SGA, the incidence rate would shoot off the roof. So I'll just display this video and I would like to invite the responses from the audience that what are you observing? So he's a young chap who left his medication and then he came to the OPD 2 days before. So we recorded his video and we thought that we'll share with this. So if you go to the starting of the video, so you can see this. So what you can see, please share your responses. I think I've not got any response till now. people are warming up, I suppose. So see, we can see, if we see the starting of the video, okay, tardive tremors, okay, the bilateral course tremors, yes. So this is bilateral, and you can see that the amplitude is pretty high. And a tremors, you can see that it is pretty. If tremors, you have to point it out. You have to actually be specifically clearly about the rhythms. The If it is rhythmic, it will be a tremor. If it is not rhythmic, it can be a dyskinetic movement. So here, a very simple clinical pointer will help us to differentiate from this video. So it is very, very close to whatever you have answered. So this patient, he left medications and then subsequently presented with 2 to 3 days. He was on clozapine. He discontinued that, and then he presented with these movements which are bilateral course as rightly answered. But when we see closely rhythm, we need to calculate if it is rhythmic, tremors. If it is not rhythmic, then it becomes a dyskinesia. So, but this is withdrawal emergent dyskinesia. But now my whole point of putting this video is he's a young chap who got disturbed with a lot of high potency antipsychotics. So when we talk about young chap, and this orange color is limbs. So limbs involvement is commonly seen in tardive dyskinesia in young people. When we talk about old age, so orobuccolingual movements are more common. So overall, the OBL kind of tardive dyskinesias are more common than limb tardive dyskinesias. But if the patient is young age, always bother to look at the limbs. Coming to clinical features, I think the most interesting section of the presentation. So this is when you see AIMS, abnormal involuntary movement scale. So it divides the rating of movements into 7 areas. So one is facial movements, facial muscles. Then there is tongue. Then there is jaw. Then there is lips. Then upper limbs, lower limbs, and then head, trunk, and shoulders. So if we see different areas, you will see different the various phenomena of movements given various names by various researchers. So we will try to address most of them. So when we talk about
Right.
tongue, yeah. Yeah, so we talk about tongue, so we call it fly catching tongue. So when there is an anterior posterior movement of tongue, so we call it fly catcher tongue. Then subsequently there is an side to side movement of the tongue, sweeping movements of tongue. We call it bon tongue. And then there is something which is known as a rippler movement of the tongue, ripple kind of movement of the tongue, which is known as vermicular tongue. So what is this? What kind of movement is this? So a movement which resembles a kiss. So the child is, yeah. So you can see that it is puckering. Okay. This, so this is, so lip smacking is this. So this is lip smacking. So this is pursing of lips. This, someone who has done horse riding will be able to relate to this movement of perioral region. This is bridling. Okay. As I said, sweeping movement of the tongue of the oral cavity, bon. This is bridling. Whatever the photo is being shown. And there is a very interesting movement known as piano playing movement. I'll show you this in the, and there is one case report of a patient who had an amputation of knee, but had an dyskinesia of that limb. But after amputation, the stump was jumping. So interestingly, they called it jumpy stumpy. So this is a video of patient who just came to the OPD. We thought we'll record it and for demonstration purpose. Can anyone tell us what you can see? So we can see perioral movements are involved. Slight twitching of eyebrows were there. There is this puckering and slight uh, occasional pouting is also there. So pouting is when child will cry and he would want to have something, he will do this. Or you can see him in the camera. So this is pouting. So but you can see a puckering pouting movements here. So again, please, I would like to challenge everyone's observation here. What you would see in this video. Again, I'll play this. You can see, there is slight movement of anyone can answer in the chat box. What you could see in this? Bon sign. Okay, I'll play this again. So you can see as there is some perioral lip movement, you know, some kind of an pursing was there, and then you can see this tongue thrusting out. But when we asked him to open his mouth and then subsequently protrude his tongue, it was not evident. So a very subtle observation will help us in diagnosing it. So someone of you have answered lingual dystonia. So lingual dystonia will not be hidden. So if you open your mouth and ask the patient to do some action, dystonia worsens. So again, an interesting one. So these are the videos I have taken from CNS spectrums. They are pretty interesting. So please post your response in the chat box. What you can appreciate in this video. Lip smacking, yes. Oral dyskinesia, Dr. Abhijit has answered yes. Bonbon, yes. If you can see the tongue is sweeping inside, yes. You can see this. Tongue will thrust here. When there is perioral, there is a puckering was there. Lip, slight lip smacking. Don't forget this trunk movement. She is also swaying in the trunk. There is a slight abnormal trunk movement also. You can see the descriptions I've shared. Irregular repetitive movements of mouth, lip, tongue, along with increased blinking and trunkal chorea is there. So another video, what you could appreciate, please let me know. So I don't want that you should miss subsequently any of the dyskinesia subsequent from now. Yes, piano playing. So you can see the fingers, piano playing movements. Yes, you rightly answered. Then something with the trunk. If she would have actually moved sideways, would have been more clearer. But there you can see some truncal dystonia. Yes, some dystonia is also there of the upper limbs also. So you're right. So this is again another video. What you could appreciate again, specifically in context of TD. You can see he's swaying, he's having slow movement. And it is involving most of the body parts. So this is choreoethetoid movement of trunk, legs, hands. So it is generalized movement. So you can see it was seen that as if he's enjoying some music, he's dancing. A very slow dance. Yes, trunkle, you're right. This is an interesting one. You can see as if he's chewing tobacco. What movement? I'm waiting in the chat box. We can see occurring. Bonbon, we can appreciate probably yes, है ना? And he is having, yes, he is having puckering, and maybe some uh, inversion of lips is there. So he can, and don't forget truncal rocking. So we get too focused by this. Truncal rocking is important. What all you can see in this video? So you can see this area is involved here. Dyskinesia is very good. Lip smacking, it, and swallowing, puffing, tongue thrusting of mouth, jaw, and tongue. So you can see perioral dyskinesias are there. What else we can appreciate in this video? Forget about this region. So if you can see, the neck is extended backward. So he's having retrocollis. So again, so maybe an element of tardive dystonia. As I said, tardive dystonia is added in this video. Retrocollis, yes. Oculogyric is different. Oculogyric, we will see. Oculogyric is when eyes will be deviated upwards. So here the eyes are following the head direction. So when there will be eyes will be deviated upwards or downwards. So we call it oculogyric crisis. So this is the reference. You can all please go and read it in detail. And it is an ever learning process. So coming to pathophysiology, how it develops and why it develops, frankly speaking, we don't have much answers to it. Despite the whole research going around, there are a few hypotheses. I'll just touch upon a few. Involvement of corticostrato-thalamocortical circuits, direct indirect circuits. So we know that one of the direct and indirect circuits, they will induce and they'll inhibit movement. So when there is a dysynchrony in between the two, so there is asynchronous movements would come up and resulting in dyskinesias. But when we see what theories, there are three kind of pictures available. First is disease-related vulnerability. Then there is genetic vulnerability, and then there is antipsychotic induced vulnerability. So disease vulnerability, as we said that we discussed about spontaneous dyskinesias. So the disease in itself creates this subgroup. There is some subgroup of patients in schizophrenia who now people are saying that they're having subcortical psychosis. They are more vulnerable for developing these dyskinesias. So disease in itself results in these vulnerabilities. And as I said, spontaneous dyskinesia has a huge range. So average is 5%. So the prevalences has a huge range, and the siblings have some TD-like movements, and they have a highly elevated synthesis of dopamine in striatum as per the scans. And interestingly, the poor response to first episode psychosis is an somehow it correlates with TD development. So that is why they are saying that disease in itself is creating this vulnerability. Please do not hold our psychotropics for everything, every nook and cranny which crops up in the patients. Disease genetic vulnerability. Yes, so there are various genes. I'll not go into the detail. This is probably beyond. You can all read this. And then there is something known as this SLC variant, where it will actually it is a polymorphism which encodes for vesicular monoamine transporter 2, which is a VMAT inhibitor. It encodes for VMAT inhibitors, VMAT transporters, which are subsequently inhibited by drugs implicated in TD. Then, importantly, antipsychotic induced vulnerability for the purview of PGs. This is important. When we talk about dopamine supersensitivity hypothesis, a lot of people they probably do not get the hang of this. I'll just provide some justice to this. So when we talk about these dopamine receptors, these are D2 dopamine receptors, and this is available dopamine. So in the synapse. But when we say that drugs would block these receptors, D2 receptors, antipsychotics will block these D2 receptors. This will, in other areas of the synapse, there will be compensatory hyper, they compensates and the density of receptors would increase in the synapse. And the available dopamine would look for places to subsequently get attached. Sorry. So what happens, this available dopamine, because of the high density of D2 receptors which are there, it will go and attach and basically will induce this movement. So and this is the whole concept of dopamine supersensitivity hypothesis. So and it will exaggerate dyskinetic symptoms. Now why it is important even more that this hypothesis closest to whatever hypotheses are there around, that when we increase the dose of antipsychotic, so supposedly this is haloperidol, so when we increase this first generation antipsychotic, so it will cover these receptors also, that the higher dose, maybe the patient is having 10 mg and patient develops 10 mg and TD with this synaptic architecture. So if the patient increase the dose to 15 mg, 20 mg, so it will block these receptors also, and it will result in transient improvement of tardive dyskinesia. So here it is a paradox that the drug is inducing tardive dyskinesia, but drug at a higher dose is masking or temporarily improving or suppressing or attenuating tardive dyskinesia, the dyskinetic movements. So this is interesting. So that is why dopamine supersensitivity hypothesis is applied till date. And when we talk about atypicals, why they are causing less TD, though the difference is not very huge. So because of, again, in context of dopamine supersensitive psychosis, the striatal receptor, the blocking density of a second generation antipsychotics is lesser than first generation antipsychotics. So lesser D2 hypersensitization, or the D2 receptor density would be lesser. And we know this very famous hypothesis, famous enough that CTP has dedicated 3 to 4 lines on this fast dissociation hypothesis by Kshitij Kapoor and Philip Seaman. So I'll just provide some justice to it. So supposedly there is this older medicine. I'll go again. So this is an first generation antipsychotic, haloperidol. So the molecule, it goes and it tightly bonds the receptors and it doesn't leave it, and very slowly it will dissociate. When we talk about Q-tipin and clozapine, so it will go there and it will dissociate fast. So this is known as fast dissociation and this phenomena. And this is the phenomena which probably results in less D2 hypersensitization and less TD. So this is the whole ball game of fast dissociation hypothesis. So coming to another hypothesis, this is the last hypothesis I'll go into. Other than that, I'll summarize. So when we talk about normal brain, we know that we have studied this balance in Parkinson's, in context of Parkinson's. So choline and dopamine, so they are balancing each other. But when we give antipsychotic, dopamine will reduce down, choline will increase, acetylcholine will increase. So when acetylcholine will increase, uh, this basically the fibers which deal with this choline, because of excessive choline, they go into an auto burnout kind of a phenomena. And subsequently, when we give an anticholinergic drug, so the burnout, the relative dynamic balance goes even more for the toss, and there is a worsening of TD. Again, this is an hypothesis. There are various other hypotheses, so I'll not go into the details of it. I think interested residents can read this. Now, when we talked about the basics, the historical, the evolution of it, then subsequently we have also talked about the conceptual evolution. We have talked about the clinical features. We have gone through various videos, the phenomenology of movements, and the pathophysiology. So much so, but what is important is if someone comes in front of us, whether that movement is TD or not, with a very compromised history, so how to differentiate only by astutely seeing, and mind you, it is not an easy, it's not everyone's cup of tea. You need probably loads and loads of experience, time to develop those patterns, and then there are very high chances of committing mistakes. So one by one, I would like to invite the response in the chat box. So this.
Do you have anything in your mouth like
These are
gum or
movements.
candy?
No.
Are you having any problem with your teeth or dentures?
No.
Do you usually wear dentures?
No.
So these are which movements, and as a differential to dyskinesia, tardive dyskinesia.
Do you have anything
can
in
see
your
this,
mouth like gum or
rest
candy?
tremors.
No.
These are
Are
probably
you
more than
having
one
any
plane.
problem with your teeth or
And
dentures?
these are
No.
Parkinson's tremors.
Do you usually wear dentures?
Okay.
No.
And when you count, there is a rhythm to it, and maybe around 5 hertz or so. This is one of the patients who came to us. This is a video. So you can see this. He took his hands back, then he thought of, okay, I'll fold my hands. He's shifting his posture in the chair, and then he had a sudden, I would say, he tried to hold his abdomen back. So what are these movements? Anyone, please? I would like to invite the responses in the chat box so that everyone is with me. Tics, quasi-purposeful movements. Dr. Mankaran has replied. Dr. Kusu has replied tics. Dr. Kusu will come to tics. Akathisia, chorea, yes. Things are getting very interesting. So when we see the video, so you can see the every movement he is doing is abnormal. So that is an interesting part of the video. And so there is a truncal movement. So the movement which he held his hand back. So he's actually trying to probably show us that he is serving some purpose, folding hands, shifting his posture in the chair. And they are pretty non-rhythmic, random kind of movements. So this goes in favor of chorea. So another interesting one, you can see this. You can see again it is generalized movement, which is pretty random, involving most of the body parts and very high amplitude. And at times, ectotoid movements of the right arm, closer to high amplitude chorea. So, but it is important that clinically we should also differentiate how TD is different from chorea. So you can, if the drug history is not available, it becomes very difficult because chorea, we give antipsychotics. TD, we avoid high potency antipsychotics. So chorea, the typical age is, or Huntington's chorea, is typical age is 40 to 50 years of age. But when we talk about chorea, it is the movements are more generalized. The speech is involved, the gait is involved in chorea. You might find dystonia, as we showed you one of the videos of the patient in the white clothes. He had a gait issue. We couldn't record that portion of his disease. And then we see that cognition and other symptoms, and then dementia, progressive dementia will come up. But phenomenologically, these subtle cues are important. And TD, generally the amplitude is less. It is we see that OMD TDs, oromandibular dyskinesias, orolingual movements, there the amplitude is less. The peripheral amplitudes are less. So again, so this is broadly how we can approach, but at times can be pretty colored. What are these movements?
The patient is having difficulty in gripping the object, particularly the finger. This is called the.
So I've hidden
The
the
patient
answer.
is having.
What is this? This lady who was gripping the fingers of the doctor and the clinician. Yes. So I think we should congratulate you. It is milkmaid grip, or it is you find in Sydenham's Korea. Yes. So coming to this video, it's an interesting video. What is the phenomena? So you can see, I think I'm shooting time. So perioral movements, you can see there is This is periocular movements are there.
आपका नाम क्या बेटा?
This is tics.
और कौन सी क्लास में पढ़ते
And
हो?
you can see there is an
स्कूल
slight dyskinetic
Okay.
movement
दोस्त
of
है
the
आपके?
cheek. This is tics.
कौन कौन है फ्रेंड्स आपके?
You can see this. There is a movement
कौन?
of this forearm muscle also. This is also a
Okay.
tic. So these were example of motor tics. You can see, I think the volume is not available. So this is an example of a child who was repeatedly grunting out unformed voices. So example of vocal tics. So this is an interesting video. We have actually trying to report this case. This is a girl who came to us at 18. Since 13 years, there is global cognitive decline. She has lost all the mental faculties, completely dependent on the mother, and she would repeatedly do these clappings in a rhythmical manner. So this is a stereotypic disorder. So stereotypies. But when we investigated this case, we found that there was an leukoencephalopathy. We could found a leukodystrophy in the MRI. MRI there was whole MRI was having the cortex was demyelinated. So we subsequently thought that it was Alexander leukoencephalopathy. This is an interesting video.
बैठो क्या खड़ा कर दो यहाँ पे ले लो
So got it from the emergency.
चोट नहीं लगना
You can see he's having sideways truncal deviation. Sideways truncal deviation. And the child accidentally took 10 times of the dose of risperidone which was prescribed and subsequently had this drug-induced acute dystonia. If it is involving sideways movement of the trunk, it is known as PISA syndrome. So, but when these movements would come to us, supposedly I'm very confident that I've diagnosed someone as having dyskinesia. How to differentiate that alternate etiologies involved? These are the few clinical snippets, like maybe an atypical movement for TD. You're able to localize some neurological signs. The onset is not insidious; it has come suddenly. A lot of areas of the brain are involved. Generalized movements are there. Family history of an abnormal movement disorder is there. You won't find any temporal association with any dopamine receptor blocking drug. Mind you, not even metoclopramide, levosulfide, which is given very frequently now, or famous DOM-DT, domperidone and all. Then presence of alternating drugs or substance use. Then neuroimaging is abnormal because in TD you will not find any structural abnormalities. Then unexpectedly any treatment failure, patients not responding to the medications or not tolerating treatable dosages. So I think you should suspect some alternate etiology and probably ask your neurology colleagues or friends to collaborate. Coming to management, so management means investigations and treatment. So here I would like to assess the patient on various scales for TD. The most famous scale is abnormal involuntary movement scale. I'm sure every resident in this session would have applied this, but there are few issues with the scale, which is asked in exams also. That it doesn't rate the frequency; it only rates the severity. Then there are other scales like ESRS, extrapyramidal symptom rating scale. We ask our residents in exam always remember four scales for any disorders. The positive about ESRS is it is a multi-domain. It also assesses frequency. Then Simpson dyskinesia rating scale. It rates each movement discretely, but then the each movement discretely being rated is difficult with AIMS. It is more of a generic rating in AIMS. Then Smith TD scale, it's an old scale. So if we come into AIMS, so we can see it's a five. It's a scale which is subsequent. It's very famous scale, but the only issue is with the global judgment because then here the bias might come up because a lot of subjectivity they have put it. So that is a drawback and doesn't rate tremors also. When you should apply TD, the AIMS in patients, this is a matter of a lot of guidelines. I've given it differently. I've tried to summarize it very easily. For first generation antipsychotics, rate every 6 months. For second generation, annually. But be clinically have clinical suspicion in every visit. I would say high risk populations do it, a little early. First generation it was 6 months, but for high risk population, all the risk factors do it every quarterly, and for second generation it was annual, but do it every 6 monthly. Now, interestingly, you know all this that these are known as Archimedean spiral, which neurologists will use a lot to diagnose something known as essential tremors or Parkinson's tremors. But this is being used by some computerized measures. A quantitative measure has been discovered, which will actually pick up TD from handwriting disfluency. It's an interesting one, but I'll not go into the details of it. Coming to straightforward, there are other scales also of TD like lifestyle management, the lifestyle quality of life. So those are also important parts because TD in youngsters involving or in adults involving the peripheries or the oral musculature can impact the social adjustment. When we talk about evidence, so this is important that evidence, moderate evidence is for clonazepam, which should be given less than 3 months because of risk for abuse, and ginkgo biloba. But weak evidence is for amantadine and tetrabenazine. This is important because a lot of us use tetrabenazine. But as I teach residents that please, you should know what not to give before you know what to give. So this is very, very important in clinical settings. So we should not use diltiazem, galantamine, and icosapentonic acid in the form of the fatty acids, essential fatty acids, because there is an evidence that it can create more harm. Then we can see everything came into the market and it was launched. Subsequently, they couldn't establish the evidence. And most of the drugs here you can see vitamin B6 will come back to vitamin E and vitamin B6, melatonin, buspirone, levetiracetam. So even botulinum toxin. So there isn't the evidence is insufficient. Two also for ECT for then this is important that many of us say that okay, TD, you switch patients from first generation to second generation or withdraw the drugs causing TD, but evidence doesn't support it. So there is an insufficient evidence for this strategy. We'll discuss this. FDA approved drugs, there are two drugs like valbenazine and tetrabenazine, which is approved for FDA. So then that means the evidence is there. But this recent meta-analysis, because what we used to give was vitamin E to a lot of patients, and we used to rate improvements in the patients. So I was wondering that why there is an insufficient evidence, but I think this, fortunately, this review, it has established that role of valbenazine, which is not available in India, so it is useless for us as of now. But vitamin E we can give to these patients, 400 units, 600 units. Coming to case vignette to establish the agenda till now and also help you with the management. I think everyone, please be with me. This is a patient we know, 45-year-old mechanic, raised into traditional antidepressants, having recurrent major depressive disorder, currently in remission, 15 years on sertraline and adjunctive aripiprazole, 5 mg, high risk relapse requiring maintenance treatment. But now he has developed involuntary movements. His co-workers notice his distress was losing control over these movements, fear they'll worsen, potentially affecting his work on cars, a job he loves. This concern is triggering his depressive symptoms. Diagnosis mild TD. Now, what will be your approach? Please share your responses in the chat box. You being in clinician position, what will you do in his case? So Dr. Anil has said the diagnosis is a recurrent major depressive disorder and it is in remission. Patient is on sertraline, patient is on aripiprazole, patient has developed TD, mild TD. So what uh, clinical steps you're supposed to do? Or you're a resident, you are in the emergency, you're not able to access your consultants, slow tapering of aripiprazole. Okay, one option was shared is clozapine, one option is shared is slow tapering of aripiprazole. Yes, and he's pretty distressed by this, by the TD. Even if it is mild, he is again losing hope. So these are various options. We will switch his antipsychotic to one with less risk of TD. We'll add valbenazine, deutetrabenazine using low dose due to CYP 2D6 inhibition by aripiprazole, sertraline, and these agents. This is a different issue, but valbenazine is not available with us. We need to supplement his current medications with ginkgo biloba. discontinue aripiprazole and increase the dose of sertraline. One of the chat box responses is Inderal. So how to go about it? So I would say that the clinical approach is, once we have established the diagnosis of TD, we have rated it with our scales. If it is a mild TD and uh, or the risk of relapse is high, so it's if the patient is having the patient is established on antipsychotics and a lot of relapses have occurred, and with very vigorous efforts patient is stable, so we need to continue it same. But if it is distressing, we need to subsequently evaluate it. But if it is a severe TD or the risk of relapse is low, so we can taper and consider second generation antipsychotic. As rightly said in the chat box, clozapine, but not in the current case scenario. In current case scenario, because the patient is stable but having mild TD but still distressed, maybe some reassurance, psychoeducation, or if it doesn't agree, maybe reduction of dose of aripiprazole, adding vitamin E might, or ginkgo biloba might help in his case. And tapering anticholinergics is important. That is what the consensus says. If this doesn't respond, if this study doesn't work, so if you're not able to consider another antipsychotic, and this scenario doesn't work, tapering anticholinergics doesn't help him, vitamin E doesn't help him, we basically then will go for PMAT inhibitors like tetrabenazine. Valbenazine, deutetrabenazine is not available. But problem with tetrabenazine is, despite uh, being effective, it has a lot of side effects. And one of the important side effects of tetrabenazine is its metabolite causes extrapyramidal Parkinson's, drug-induced Parkinson's. So the patient comes with TD and subsequently carries drug-induced Parkinson's with him or her, then it becomes a even more bone of contention. Some miscellaneous issues when we talk about TD. Does TD affect cognition? There is a review paper. There's a paper, interesting paper. It said yes, TD, specifically orofacial scores or OMD kind of TDs will correlate with attention, but limb and trunk scores will correlate with visuospatial abilities. Mortality, TD with mortality, yes. So TD has shown that it shortens survival, and then when compared to patients with TD, patients without TD, then and modest increase in mortality, and causes are like severe TD, respiratory TD, exhaustion, falls, poor nutrition, dysphagia, and pneumonia. So this is important. Neuromodulation, because it's my interest area. RTMS, there is an RCT now which has handsomely shown improvements in TD. I think we all can go and read this and use it on patients, because at times in psychopharmacology we are left with no option. TDCS, they have brought out an RCT, recent RCT, where they said left dorsolateral prefrontal cortex activation protocol. It actually has brought 50% of improvement in TD. Deep brain stimulation to the pallidum, it has shown that there are case reports of case series. The maximum sample with case series reported is 12. So they have shown improvement, but it's an invasive process. So it comes with its own issues. Vagal nerve stimulation, magnetosensor therapy, high definition TDCS, other cranial nerve stimulations, it has not been reported. So it's a barren area. You can all can pick this up as a research proposition. Coming to last section, whether TD is reversible. Is TD is reversible? We treating TD, we change the supposedly the current patient, I change it, I taper his aripiprazole, I give him vitamin D, I settle him down. Whether that mild TD will reverse. So as I said, in school ranking criteria, 3 months is a critical time. If the movement surpasses 3 months, the chances of TD persisting and not going back is very high. So early detection, early reporting of TD, early withdrawal of medication, offending agents, protecting patients with some antioxidants like ginkgo biloba, vitamin E can save us. Otherwise, when we see the data, the remission rate is as less as 2%. So this is critical data. So again, so TD can be an enduring problem with the patient. With this, I think I like to wind up. sign off by paying my regards to where I was taught my that I did my MBBS post graduation in my current place. Thank you.
Thank you so much, Dr. Shobit Garg. That was wonderful masterclass on detection of tardive dyskinesia. And I think only when you see such patients and you have it in your mind to closely observe, that's only time when you will pick up, because these are symptoms which patients may not come and report to you unless it starts hampering their functioning. So it's the onus is on us to, and that was beautifully depicted, and your videos were awesome. Can we take a couple of questions? Can you,
Yes, ma'am. Yes, ma'am.
yeah, can you please post questions on the chat, audience? Well, there is a question. Can clozapine reverse tardive dyskinesia?
Yes, sir. I think an interesting question. Dr. Kusuma has put this up. See, that is the whole point is if we cross that barrier of 3 months, so we can mask TD. So if someone is on clozapine, the dyskinesia will come down, the amplitude will come down, you will not be able to observe it. But the whole point is ki if we withdraw clozapine subsequently later on, whether that will come up or not. So this kind of a data is not a very robust. No one has actually systematically studied this. So a lot of information we have is from observation data, case series, case reports. So as I shared in that last paper, so the remission rates are very poor if it persists for more than 3 months. So clozapine can mask it, but it might come back, it might not come back. In how many percentage of cases, we still don't know. But I think to provide relief, when what I do is 6.25 mg of clozapine I'll put, even lesser than that, so that it actually suppresses TD and it helps patient not compromising on the sedation profile or clozapine side effects, just to provide comfort to the patient with TD.
Well, there is another question. How much should we be revealing it to the patients, and whether that would, result in non-adherence to the medications?
Very important question. The golden rule of thumb which we follow is reveal all the side effects which are more than 1% prevalent in the patient when we start a treatment. But I'm not sure how much we do, how much we psychoeducate. The problem is most of the patients will come to us in symptomatic phase, family is distraught, everyone is distraught. Our whole attempt is just to bring the symptoms down, and maybe in cases of drugs like clozapine we do frequent monitoring. So clinical monitoring is important. Earlier we detect, and most of the family members are having very high express emotions. So I'm not sure that whether that kind of an information may provide immediate benefits to us. Maybe case to case basis we can take. Maybe if the guardians are pretty informed, we can tell them there is very less chances of doing this. We'll keep the monitoring on, but if it happens, we'll immediately change the treatment protocol. You also monitor it. So that kind of a thing is there. But an approach which is not an empathetic approach and computerized approach where we jot down all the side effects and just verbatimly put it in front of the guardians can be difficult if we are dealing with psychosis treatment.
Thank you. Dr. Ashman would like to know whether primary tics and mannerisms occurring in a patient along with tardive dyskinetic symptoms, can they be confounding factor? Can the primary tics and mannerisms come in the way of diagnosis of TD?
The mannerisms will not come up immediately. So mannerisms, this is an interesting question because one of the patients who come to us with nose rubbing, and we thought that we'll put a video of his, but we were not very confident on the phenomenology. And then we thought ki these are nose rubbing tics, and he is having other extrapyramidal side effects. He's a schizophrenia patient. He's on clozapine. So then when I said that this is abnormal, father said, no, this I also do. I also do it from my childhood. So probably this is mannerism. So first of all, mannerisms will be present from pre-morbid phase. So when we talk about tics is a different symptom altogether, where there is a premonition and it'll have it. It is again non-rhythmic, but it will come in clusters. Very importantly, you need to remember that in tardive dyskinesia, patient will not be able to suppress the movement for more than 1 second, as per your primary CNS companion. But tics, patient can be able to suppress for some duration. Maybe in front of your chamber also, child can suppress tics, but when we go out, he'll throw a lot of tics. So you have to remember this is a very clinical subtle pointer. TEDs, they'll not be able to suppress for more than a second. So maybe that can help us and bring down these confounds lesser and help us to precisely diagnose these patients and subsequently take them to research if your context question is in this context also.
Well, Dr. Anil Kumar wants to know whether there is any role of Primavers, and you can also, Dr. Kusuma once again wants to ask the dose regimen of ginkgo biloba and vitamin E.
So
Maybe you
ginkgo
can.
biloba, I generally give it in 120 mg daily dose. So that is a formulation 60 mg, 120 mg, 180 mg. Generally 120 mg is good enough because it is pretty costly also. So in our setup here, it is difficult for us to prescribe nutraceuticals in varied amounts. Regarding the dose of vitamin E, so there is a broader range. So 400 to 800 to 1200 to 1600. People have given various dosages. Regarding pimavanserin, sir, I'm not sure. I'm not come across. I've not used them. Use these because it doesn't work at all in dopamine pathway. It doesn't block the D2 receptors at all. So I hope that it doesn't cause any TDs. We have just drafted a protocol in our medical college, and we actually tried to use pimavanserin in the patients who are more vulnerable for extrapyramidal side effect. So what we did is, see, we in schizophrenia we applied an extrapyramidal rating scale, and we tried to include those patients who are vulnerable for antipsychotic side effects, and we gave them pimavanserin, but we couldn't find any therapeutic benefit. So we had to abort that trial actually. So I'm not sure that. So in that sense, it is very safe, sir.
Yeah.
Because
Actually, I have personally never used ginkgo biloba because here we don't use any nutraceuticals. I mean, that's our hospital policy per se. So I was surprised to know that it helps in.
and
Uh,
it's pretty, ma'am, encouraging response in ticks, I would say, ma'am. So
I
ticks.
see. Okay. But anticholinergic use, I think, I mean, there are a lot of, previously we used to have a lot of combination medications which had, like even now we have trifluperazine plus, uh, trihexyphenidyl. And we were taught right from the beginning in our UG days itself. I mean, I remember my professor who used to say, ki after 3 to 6 months of use of anticholinergics, please taper and stop. And if needed, then give the lowest possible dose. So
Yes,
I
yes, ma'am.
think stopping anticholinergics help to a large extent.
Ma'am, you're
Even
absolutely bang on because as per American Psychiatric Association, 4 months after 4 months of anticholinergic intake, we need to review the whole prescribing strategy, do a brown bag review of the medications, and try to always taper anticholinergics because of ever lingering effects on cognition and also now risk for TD. So I think that is why this, but I am not sure because of trifluperazine being available in combination more frequently. So whether that can be done in that combination actually.
it's a risk. I've been telling the pharmaceuticals, ki please get for
Available.
a while we had plain trifluperazine.
Yes,
It was available in Mumbai, so that was convenient that we could switch to plain and then once the patient is stable.
yes, ma'am.
Yeah, I think there's one last question with that should be wind up. When adolescents develop TD, they would require a VMAT inhibitor for a prolonged period. What other options can be suggested?
That is what my whole point is, that VMAT inhibitors, specifically when you talk about valbenazine, it is not available in India, so we don't have any first-hand experience of it. By the theories which we know, that valbenazine is an OD preparation, the tetrabenazine we have to give it 3 times a day. Valbenazine has relatively lesser side effects than tetrabenazine. It bypasses the issue of drug-induced Parkinson's which we encounter with tetrabenazine. So so we do not have the first-hand clinical experience. But when you talk about tetrabenazine, yes, because of its side effects, I have to withdraw it in a lot of patients. Or I have to give it in very, very light, smaller dose, but then it doesn't provide a therapeutic benefit. So I would say that in adolescents developing TD, be skeptical, immediately diagnose it, probably change your strategy, go to close-up in so that 3 months window is saved, and use other agents or safe agents. Nowadays, people are not using high potency antipsychotics in adolescents for so aripiprazole is relatively safe. The case magnet I put it for the discussion sake, but the high dose risperidone or haloperidol, those kind of agents generally in context of adolescent psychosis, there is not that much used which were used before. I use it frequently, but I'm very, very skeptical on screening that they do not land into any of the side effects. So the whole point is if the child lands into persistent TD, then this will go on for a very long period of time, and the evidence for VMAT inhibitors which are available in India is very poor. So we don't know. I don't know that how valbenazine, how much effective it is. So how to go about it? And tetrabenazine is poor. So it's an area which I cannot put an answer to you.
Yeah. Shall we wind up? If there are no more questions.
Yes, ma'am.
Yeah. Rashmin, you're on mute.
I am sure. Can you hear me?
Yes, sir.
Yeah. All right. Lovely. Thank you very much. And I think I don't have words. It's such a brilliant talk. And the beauty of it is that it dealt with a very complex topic in a very, very back to the basics kind of a manner. But the lucidity and the clarity with which you presented the entire topic was really fascinating and absolutely brilliant. Shobit, I can't say anything beyond that. Of course, the audience interaction was proof of that. So I think this lecture will definitely be visited multiple times on the website. As I'm sure all our audience knows, these are uploaded to the website within a couple of days of the talk. And we have people coming and visiting the website to review these lectures on multiple occasions. So the attendance is just a small fraction of the number of people who actually benefit from these lectures. So it was great to have you on board, Dr. Garg, and thank you, Dr. Shobha Nair, for being with us and making the time to chair this important session. And you added a lot of value to the whole discourse. And of course, to all the audience who participated very enthusiastically. We promise to bring you such exciting topics. In fact, Dr. Garg had alluded to a couple of other topics which are right up his alley. So we are going to request him to be back on this platform in due course of time. I'm sure he will do us the privilege of teaching us a few more areas of psychiatry which are very interesting. So thank you all once again, and thank you, Sun Pharma, for your unflinching support. And we will be back again next month with another interesting topic, and we look forward to having you all with us again. Thank you all, and have a great evening ahead. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you.
Thank you.